Hello everyone. In this video, I am presenting a case report on unusual presentation of uterine perforation after 2 days of dilatation and curettage procedure in a scarred uterus with intra-abdominal extrusion of fetal parts. I am Dr. Kalaivani, Assistant Professor in the Department of Obstetrics and Gynaecology in Sri Venkateswara Medical College Hospital and Research Center, Puducherry, India. An outline to this presentation includes introduction, case report, discussion, conclusion, and references. Before going to the case presentation, let's have a brief look on unsafe abortion and dilatation and curettage procedure. As we all know that unsafe abortion is the fourth most common cause of maternal mortality, which can be preventable with prompt diagnosis and treatment. Unsafe abortion is defined as a surgical abortive procedure carried out by healthcare professionals who lack proper skills or at a facility with inadequate resources for abortion or both. Uterine perforation is a life-threatening obstetric emergency with a reported incidence of 5.3 per 10,000 procedures according to the WHO. Dilatation and curettage is a universally accepted safe procedure for retained products of conception, termination of pregnancy, as well as post-abortive management. The reported incidence of uterine perforation after dilatation and curettage procedure in first trimester is 0.05% and in the second trimester of pregnancy is 0.32%. The estimated overall risk of uterine perforation is 0.8 to 6.4 per thousand procedures and 0.006 to 0.012% in unscarred uterus and primigravida. Depending upon factors such as age, parity, pre-existing medical disorders, uterine anomalies, maternal infections, type of anesthesia, as well as healthcare providers' technique and experience, the risk of uterine perforation increases during DNC procedure. Uterine retroversion does not contribute risk of perforation significantly. Nearly 15% of uterine perforation cases are associated with bladder and rectal injuries. The clinical manifestations of uterine perforation depends on its site and size, which includes continuous abdominal pain, bleeding per vaginum, bleeding into the abdominal cavity, that is hemoperitoneum, and extrusion of fetal products into the abdominal cavity, hematuria, and hypotension. Uterine perforations are generally small. The most common site is anterior uterine wall, which accounts for 40%. The second most common site is cervix, which accounts for 36%, whereas 21% of uterine perforation occurs in right lateral wall of uterus, 17% occurs in left lateral wall of uterus, 13% of uterine perforation occurs in posterior uterine wall as well as fundus of uterus. The most dangerous site of perforation is at the level of internal os and uterine lower segment, as they may involve uterine vessels. So, we need prompt diagnosis and management to prevent severe consequences of the DNC procedure, especially in cases of spontaneous or therapeutic abortion, to significantly reduce maternal morbidity as well as mortality. Although all cases of uterine perforations are detected early, in rare cases the fetal parts may protrude into the abdominal cavity and symptoms of internal bleeding may gradually develop. We hereby report a case of uterine perforation after TNC procedure in a 28-year-old woman who presented with massive hemoperitoneum and bowel obstruction. In this case presentation, a 28-year-old woman presented to our obstetric casualty with complaints of severe abdominal pain, abdominal distension, and history of moderate bleeding per vaginum since morning. Her obstetric history included Gravida 3, Para 1, Living 1, Abortion 1 with a history of caesarean section 1 year prior, and 6 months back history of induced abortion was performed for 3 months of gestation. 2 days before admission, she underwent a elective dilatation and curettage procedure at a private clinic for 19 weeks of gestation following an accidental fall, which was complicated by bleeding per vaginum with passage of clots. However, the details of the procedure were not available at the time of admission. She was discharged from the private clinic having been assured that the procedure had been completed without any complications and that a post-operative ultrasound scan was not required. 2 days after the procedure, she gradually developed abdominal distension, nausea, vomiting, giddiness, and breathing difficulty. At the time of admission, she looks very pale with a pulse rate of 110/28 per minute and recorded blood pressure of 118 per 76 millimeters of mercury, and saturation was maintained in the room. She was mildly dyspneic at the time of admission with a respiratory rate of 22 per minute, and she was afebrile with abdominal girth of 92 cm. On per-abdomen examination, lower abdomen was distended, rebound tenderness was noted, bowel sounds were sluggishly heard, and dullness was noted over the flanks. On per-vaginal examination, uterus corresponds to 12-week size approximately. Posterior fornicial tenderness was noted with closed internal os, and foul-smelling bloody discharge per vaginum was observed. Basic investigations were sent, which includes hemoglobin of 9.7 mg per deciliter, total count of 26,500 per cubic millimeter, platelet count of 276,000, RBS was 82. Whereas serum urea was elevated to 77, serum creatinine was raised to 2.1, and coagulation profile was normal before surgery. A transabdominal ultrasound was performed, which revealed a significant fluid collection surrounding the uterus with mobile internal echoes. Within the uterine cavity, multiple echogenic foci are noted, which are likely to be air foci, and the findings are consistent with the possibility of uterine perforation, but uterine defect was not identifiable. X-ray abdomen was taken in view of distended lower abdomen. Erect view shows dilated bowel loops suggestive of small bowel obstruction. She was conservatively managed with IV fluids, antibiotics, analgesics for stabilization. Contrast enhanced CT abdomen was not done due to deteriorating condition of the patient. A provisional diagnosis of uterine perforation with massive hemoperitoneum and bowel obstruction was made. Patient was taken up for emergency exploratory laparotomy, and the abdomen was opened by vertical incision. And the intraoperative findings were 800 ml of foul-smelling hemoperitoneum and 600 ml of Ryle's tube aspirate was drained. Fetal parts were removed from the pouch of Douglas and abdominal cavity, which includes a right fetal foot, which measures to about 2.8 cm, which corresponds to 18 weeks of gestation. Piecemeal parts of placenta and its membranes with bony spicules were removed from the abdominal cavity. Uterus was adherent to the anterior abdominal wall in the lower uterine segment and the bladder, and the same were released. Peritoneal surface swab was taken. Rent of size 3 × 3 cm was noted over the posterolateral aspect of the uterus around the lower segment. Necrotic tissues were present over the uterus and small intestine. Both fallopian tubes and ovaries appear bluish black, partially gangrenous and thrombosed. Dilated small bowel lobes noted with congested jejunum. Minimal bowel adhesions also observed, but there is no evidence of bowel perforation. And this image shows the dilated bowel lobes. And this specimen shows extruded fetal parts with uterus and fallopian tubes and ovaries. Intraoperatively, 2 units of packed RBCs was transfused. Surgeon callover was given. Emergency laparotomy was proceeded to hysterectomy with bilateral salpingo-oophorectomy with adhesive and abdominal exploration. Intraperitoneal and subcutaneous drain was kept. The abdominal cavity was thoroughly irrigated and hemostasis was achieved. The patient was closely monitored and stabilized over 48 hours. She developed the non-oliguric phase of acute kidney injury on postoperative day 2, which was conservatively managed with adequate hydration. Gradual improvements in hemoglobin, serum urea, and serum creatinine to normal values were observed, and abdominal girth returned to normal parameters. Post-operatively, she had 2 episodes of fever and broad-spectrum antibiotics were prescribed for 7 days. She was instructed to gradually adopt oral liquids and solid foods, and she was discharged on the 14th postoperative day with instructions for regular follow-up. The histopathological findings were consistent with the intraoperative findings. A defect of size 3 x 2.5 cm was noted in the left lower uterine segment extending from the uterine cavity to serosa. Piecemeal parts of fetus like face, skull bones, spinal cord with upper limb, fetal eye, hand and foot were identified. Placental tissues and membranes were measured together, which corresponds to 15 x 6.5 x 0.6 cm was noted. In regard to discussion of this case presentation, we all know that the incidence of uterine perforation in developing countries is more common after DNC procedure. Risk factors for uterine perforation includes the following conditions, which is responsible to reduce myometrial strength such as multiparity, advanced gestation age, previous uterine surgeries like cesarean section, laparotomy, laparoscopic intervention, hysteroscopic surgery. Iatrogenic causes, history of abortion using instruments, fundal pressure, inadequate augmentation of labor, placenta accreta spectrum, congenital anomalies of uterus, traumatic causes, connective tissue disorders such as Ehlers-Danlos syndrome, and general anesthesia use. For safe abortion, the type of equipment, the infrastructure of the health facility, and well-experienced gynecologists are mandatory to prevent maternal mortality. When performing surgery, a well-trained gynecologist should be highly suspicious of uterine perforation whenever the surgical instrument extends beyond the expected length of the uterus. Furthermore, if there is excessive bleeding, fat or omentum in the suction cannula, or if hematuria occurs, injuries to other internal organs such as the small intestine, appendix or omentum should be suspected. The first warning sign of uterine perforation is perioperative hypotension due to intra-abdominal or retroperitoneal hemorrhage. For patients who desires for fertility preservation in uterine perforation, catheter angiography is the procedure of choice because it has both diagnostic and therapeutic role. In hemodynamically unstable cases, temporary vascular occlusion can be performed through catheter angiography. The overall outcome of patients with uterine perforations can be improved by uterine artery embolization. Many institutions in developing countries do not have adequate facilities with 24-hour angiography service. Additionally, hysteroscopy and laparoscopy can be done to identify the perforation site. Since the maternal mortality of uterine perforation is 0.44%, the management of uterine perforation includes prompt hemodynamic stabilization by correcting hypovolemia, maintaining proper airway, oxygen supply, antibiotics, and surgical intervention like exploratory laparotomy. The potential complications of uterine perforation encompasses hemorrhage, hypovolemia, hypertension, sepsis, disseminated intravascular coagulopathy, bowel obstruction, peritonitis, renal failure, and embolism. The differential diagnosis for uterine perforation includes abruptio placenta, placenta previa, uterine inversion, cervical and vaginal avulsions, disseminated coagulopathy, uterine atonicity, and uterine artery rupture. To achieve the best possible outcome for patients with uterine perforation, timely surgical intervention should be considered. In conclusion, all intrauterine procedures should be carried out in a safe and effective way under ultrasound guidance in a recognized well-equipped centers. Our case highlights the importance of detailed pre-operative screening and evaluation. Also, it emphasizes the careful post-procedure surveillance to detect complications earlier. Furthermore, our study emphasized that immediate surgical intervention should be considered without delay in the detection of life-threatening complications. Similar to our study, two cases were reported previously. Iatrogenic uterine perforation was observed with intra-abdominal extrusion of fetal parts after 7 days of dilatation and curettage procedure with perforation of sigmoid colon. In this case, sigmoid colostomy was performed. An uterine perforation was noted in a 30-year-old multigravida woman with intra-abdominal extrusion of fetal parts as well as intrauterine bowel herniation and strangulation In this case, double barrel ileostomy was performed as a life-saving measure. And these are the references. Thank you.